This conference will now be recorded.
Hey, good evening, everybody. This is Mitch Genn with Access Laboratories, and I want to welcome everyone for coming to part 3 of a 3-part series on toxic metals. If you have missed part 1, that was the introduction and why it is so important to even consider screening for toxic metals pretty much in every patient that comes into your practice. And part 2 was how to understand the reports you get back, how to diagnose this, and how to safely interpret it to your patients. Now, part 3 tonight, we'll go into the treatment and how should we get rid of these toxic metals that are on board, because we did make it clear in the first 2 parts that even the smallest amount of these toxic metals do have serious consequences for the patient. If you missed any of these 2 parts, please get a hold of your representative over at Access Laboratories. I'm sure they'll be glad to provide that for you because we record this each time. I'm going to start showing my screen because that way we'll be able to go right into this and go into it immediately. Please tell me someone unmute and just tell me you could see part 3 and the things that we're going to be talking about.
Yes, I see it.
Okay, great. So part 3 is all about treatment. It's about how do you detoxify these toxic metals? What are some of the treatment protocol? What are the components of it? What antioxidants have to be utilized in your treatment? We're going to talk several times about the word chelation, which we mentioned in the earlier 2 components. And if this is elementary for some of you because you already do chelation, and I apologize, but we have to start somewhere. And we will give a couple protocols and we'll get into some selected health issues. I will definitely focus on IV chelation since it's my major forte. And when we'll talk about when to retest and reevaluate these people to make sure that not only is your protocol safe, but there is efficacy to it as well. At the end, I will be glad to entertain your questions as I am each time, and we'll try to make this as succinct as possible, but give you the information that you require so that you'll be able to handle these different types of patients. So detoxification pathway in the liver, as you can see here, goes through 3 phases. 1 is the fat-soluble compounds, phase 2 is the water-soluble compounds, and 3 is that which either goes out through the kidneys or through the bile. And on the bottom, you'll see a mass of nutrients that are helpful and are involved in that escape process. Why would I put it in a lecture of this nature? Because everyone's different on how they detoxify. For example, people say, well, what is the half-life of, for example, mercury or any of these metals? And most of the time, the answer is there is none. Unless the body is capable of removing it, then that particular toxic metal can last in the body for 50 years even. And that depends upon the health of your detoxification plan. So as we talk about today, these different things that we need to do, keep this cognizant because it's going to play a big role in whether you'll do a good job or not. And then when you retest, you'll know if you're doing a great job or not as well. So here are some of the reasons that people retain more toxins than others, because I already brought that up. One is they're just poor metabolizers and they don't get rid of it, or they don't have the right nutrients like we saw on the previous slide. But there are these single nucleotide polymorphisms, which basically are genetic differences, actually bother how we do our phase 1 and phase 2 detoxification that I just showed you on the other slide. I've already mentioned, but it's worthy of mention again, if you have a nutrient deficiency that is intimately involved in the detoxification process, you'll not be able to do that. And one of them, or 2 of them, for example, is zinc. So measuring the individual zinc, even by serum, would be important at your onset in your comprehensive profile. And number 2, it would be good to replete patients with glutathione, as you'll see in the protocol we do, because it takes a couple glutathione molecules to remove 1 molecule of, let's say, mercury. So if people are low in it, then you'll have a more difficult time, regardless of what agent, and even if you select the correct agent for removal. When patients are on a high sugar, low protein diet, this also hampers the safe and quick removal of these different toxins. And it doesn't take a genius to be able to realize when someone's under a lot of stress or they're traumatized, whether it be physical or it be mental, they too will have a much greater difficulty in removing this. It also depends on how much toxic metal presence do they have. And most people, if you recall from part one, have more than one. As a matter of fact, pretty much everyone has more than one toxic metal presence. And if you recall, there are what we call a PK value, and the agent that you select is going to go after certain things in certain order. So you have to be aware of that. You have to go back and learn that. And again, you have to be aware it's not just that, but it's the amount and length of time with which you provide this chelation or particular material to remove these toxic metals. And of course, if you have ongoing exposure to multiple chemicals, you're going to get a bioaccumulation. 2 is much worse than 1, 3 worse than 2, and you get the idea, 4 worse than 3. So the more toxic metals an individual has, the more potential for problems, including certain disease entities that will occur by having this. So when you have chemical sensitivity due to this overload, it is an important concept in the topic line there, because folks that have a lot of toxic metals now have a lot of adverse reactions to pretty much everything you do. So if you haven't tested the toxic metal panel, then it behooves you to do it. If they have a lot of sensitivities and many of these metals, then you're going to need to think about going much slower in those individuals, whether using IV, oral, whatever route of detoxification. So you're going to see these type of people complaining of mental reactions. They're everything bothers them. They're going to have the symptoms that we talked about in the first and second programs of shortness of breath, fatigue, muscle weakness, bowel irritation. All of these should make you even more interested in trying to get rid of these chemicals, because they will not become chemical insensitive until you're able to control the toxic metals that are in their body. Now, the treatment is in many different areas. So we're going to start where the starting should be, and that is avoidance. There is no use telling someone we're going to use a chelating agent, and we're going to give you this, and we're going to give you zeolite, and we're going to give you all these things to find out that they keep putting the material back into the tank. So the very first thing that makes sense is for you to get the list of the toxicity where they come from. For example, did they get the lead because she was using a heavy amount of red lipstick that's high in it? Was it because he got lead because he's shooting lead jacket bullets? You need to find where these come from. Be aware, as we've said before, it could come from long in the past. So this is going to be a difficult search, and often I give that concept overview to the patient. But then what I'll tell a patient to do is you need to go home and become involved in your treatment by looking into this yourself as well. Good news is Access, in their actual note that comes back in their diagnostics, does give you a hint as to where many of these could come from. But there are so many sources that it behooves you to either go into the internet, print out all these sources, and if they have arsenic and lead, give them a sheet on both, or bring them into the fold by saying, look, I'm going to do my job, I'm going to remove it, but you're going to have to do yours and find out where you're getting it. There's no use removing something and they're going to get it back. Chelation is going to be the forefront after avoidance. These two are pretty much in the order of importance. First, to avoid where it's coming from. That stops the continual adding of this particular toxic metal. Now, how are you going to get it out? The good news about toxic metals, as we know, there are chelating agents. Chelation, the call we talked about in the Greek. That means that we can go in and remove it, and by doing safe doses, which I will show you and teach you tonight, you will be able to do this with your patients. Step one, get a good feeling that the patient has a problem. Step two, go for it and get the toxic metal evaluation. You're probably going to be right 98% of the time. 3, then go ahead with avoidance and then begin some sort of chelation protocol. That's coming. With diet, there are things that have been shown to be great, such as cilantro, garlic, wild blueberries, lemon water, green tea because of the EGCG. All of them tend to help. And of course, you can also use zeolite. All of those things tend to help. But those of you that are capable or able to write for an actual agent or use an intravenous route, you're going to be, no questions, hands down, the most successful for your patient in the least amount of time. We tell patients, don't eat brown rice or rice. It has a lot of arsenic in it, if you're not aware of that. The predatory fish, the large fish that eat the other ones, have a significant amount of mercury. Non-organic foods are based in a lot of pesticides, many of them are arsenic based, etc. And alcohol as well doesn't help because it helps to divert your detoxification process to detoxifying the alcohol. Makes sense, of course. So chelation is an extracellular process. Innate detox capacity must be supported to move deeper stores. What does this mean? Okay, so when we do, for example, if we're going to use intravenous EDTA, ethylene diamine tetracetic acid, its half-life is basically 1 hour. It only removes that which is in the extracellular space. It does not go into the deep organs and pull it out. As you reduce the intracellular activity and you get rid of what's in the arteries, etc., then using your other detoxification things, it will bring it into the space where chelation can pick it up each week. We know that you need to minimize toxic exposure. We talked about that. We must make sure that our routes of excretion, whether it's bile or urine, that's phase 3 detoxification, are working well, and that's a topic for another discussion. And we want to make sure not only if there is a genetic issue with methylation, for example, that you have addressed that by monitoring the homocysteine level and monitoring and utilizing glutathione, and then of course doing the other things that we've talked about, you will get the best result. Now, the Denmark study should start us off in the right direction. It's a retrospective study of 470 patients who did get EDTA. Now, 65 of them were on a list for a coronary artery bypass surgery, and only 7 got the procedure during and after chelation therapy. Not bad. Of the 27 scheduled for amputation that had severe peripheral vascular disease, only 3 ended up. And then the study was done over 6 years in chelation treatment, and the Danish government spent $3 million. They realized the efficacy and safety of this, and they started to go ahead and utilize this type of treatment prior to the bypass surgeries and the fempops, etc. Now, this is an older study. If you look on the bottom, I always give you, and I do give you the research papers at the end. You'll see that this was from fall of 1993, but we'll come closer in time, and things haven't changed, but we'll come closer in time. Remember, in the conventional medical system, there is no medication per se, other than a specific chelating agent that is going to remove these toxic metals. If a cell is toxic with these metals, it will never perform its duty properly of the things it normally does. The more recent TACT trial to assess chelation therapy, that's what TACT is, it's an acronym, was a trial that was done not that long ago, and I'll show you. I was one of the investigators of the trial early on. It was meant for folks that were age 50 or older. They had an MI, but it had to be greater than 6 months prior. Their serum creatinine was less than 2 milligrams per deciliter, which we'll find out why in a moment. They had no coronary or carotid revascularization within the past 6 months, no active heart failure or hospitalization for it in the last 6 months. They were able to tolerate at least 500 cc's of fluid as an infusion weekly. and no cigarette smoking within 3 months. And of course, they signed an informed consent. Now, why did they use these particular exclusion or inclusion material? Was they wanted to get that person that was most likely to have coronary artery disease and see how this would fare against doing other things like aspirin, statin drugs, etc. It makes sense. And in this case, at least you're holding back those variables that could skew this particular study. So it was, I think, good in and out type of exemptions. The TACT trial resulted in a conclusion that nothing was wrong with it, and it was resumed. There was, all the hullabaloo when you do something that's not within the pharmaceutical industry's purview. Well, wait, this is not good. We need to look at it. But they did look at it, and there was nothing wrong with the way the trial was presented or performed. There were greater than 1,700 patients that were enrolled in the study, and it was presented at a meeting on November 4th, 2012, so it's a fairly new thing. And the EDTA treatment group was statistically significant in their benefits, and the paper was eventually published in JAMA, as you see, on March 27, 2013. Statistically significant subgroups involve specifically diabetics and the location of the coronary artery disease, and there were other positive things that all showed that this made a huge difference. So when you get a patient with coronary artery disease or peripheral vascular disease, you have to ask yourself, if you put a stent, are you actually treating the underlying disease? No, you are literally just doing an if-then symptomatic relief, put a straw through the obstructed area problem. So what is going to do something that will change things? Well, those are the things you and I will talk about this evening. So the trial design overview was IV chelation plus oral dose vitamins, or there was an arm that was an IV placebo chelation group and oral dose vitamins, or there was an IV chelation and oral placebo vitamins, or an IV placebo chelation and oral placebo vitamins. So that was double blinded, and the placebo infusions were shipped from a central pharmacy to the sites. And there was the to be included, you had to get at least 40 infusions, at least 3 hours each. There were 30 weekly infusions, followed by 10 maintenance infusions in 2 to 8 weeks apart. Basically, this is a well-designed, double-blind particular study where they held constant different things. They either gave placebo and placebo, or they gave the chelation and oral dose vitamins. You should be pretty much getting the feel what's going to fare the best, but if you don't, I'm going to tell you any case. So the chelation formula used in the trial, you don't need to write this or memorize this. I'm going to give you a different formula in just a bit. Was the use of disodium EDTA, not calcium EDTA, for many reasons. If you want the answer, I do not use calcium EDTA. It's a quick thing. There are no good studies on it. It is okay for lead, but it doesn't change the parathyroid movement of calcium, so it just doesn't do exactly what I would like it to do from a clinical perspective. And they basically adjusted the 3 grams downward based on the estimated glomerular filtration rate. They used 7 grams of vitamin C, 2 grams of mag chloride. Why did they use ascorbic acid in a formula? Because the ascorbic acid, there's only 2 things in the world that actually dissolve plaque in an artery and calcium, and specifically, one happens to be hydrochloric acid, which for those who do IVs, you can't use more than a 0.5 solution of 1 or 2 cc's. So that's not going to be a good clinical efficacy product. And the other is ascorbic acid. It's the only other substance known to humankind that actually helps it to dissolve. Mag chloride is used because mag chloride is vasodilatory. So they use 2 grams or 2,000 milligrams. Mag sulfate is not vasodilatory, and there are people that are allergic to it. Potassium chloride, just a little bit, 2 milliequivalents to help out with the ATP pump. And bicarbonate was used to stop any of the irritation in the vein from this. Pantothenic acid, some thiamine, and B6 pyridoxine hydrochloride. This study also used 100 milligrams of procaine. Procaine has two good uses in an IV formula of this nature. One is it is a calmative and stops the pain of the actual infusion. The other is based on Anna Aslan's work from Romania, which basically says this will break down either into paraminobenzoic acid, which is anti-aging, so to speak. It helps to turn the gray hair back to black. And the other is it gives off a weak antidepressant, dimethylaminoethanol, DMAE. It also, they use unfractionated heparin, 2,500 units. They use sterile water, 500 mLs to mix this in, which makes this solution that you see above correct from a isotonic or slightly hypertonic solution. And the placebo infusion, they just use normal saline or half dextrose, 500 mLs, and the patients didn't know the difference because both bags looked identical. Here is the conclusion of the TACT trial. EDTA-based chelation therapy reduced combined cardiovascular events in post-MI treated patients with optimal medical therapy. The 5-year NNT was 18. Now, NNT, for those that don't know what that means, is a statistical evaluation that stands for number needed to treat. So with an NNT of 18, which is exquisitely good, basically says that for every 18 people that you treat, you will get a positive result. The pharmaceutical industry basically says anything below an NNT of 30 has efficacy, anything above, which brings the statin drugs into quite question because often their NNT is in the 90s to the 300 or 450 category. But you notice this has a very good 5-year NNT, means that for 5 years, the number needed to treat is quite low. Conclusion 2 was the high-dose oral vitamins and minerals demonstrate 11% reduction in cardiovascular events, which is not statistically significant. Yet this event reduction carries over the combination of ED, chelation, and oral vitamins. So what we're saying is the vitamins had some reduction in cardiovascular events, but the combination of the both is going to do even better. The conclusion, in summary, it looks of the TACT trial, and there's ongoing one now too, is in everybody that was in the TACT trial, non-diabetics basically, the EDTA reduced cardiovascular events with an NNT of 18. Oral vitamins reduced the cardiovascular events by 11%. And number 3 is the most important. If you use EDTA and vitamins together, your NNT was only a 12. No, it wasn't the 18 plus 11, like 29%, that you saw on the other slide. That wasn't the case. But you're talking about a very low NNT. Particularly, a vitamin has an NNT of 1. It pretty much has a benefit for every individual that takes it. But this is a remarkable therapy that's available to you for patients when you check their toxic metals that you can do. Now, in the diabetics, the conclusions were the EDTA reduced cardiovascular events by 41%. That's massive, with an NNT of 7. Now, the EDTA reduced cardiovascular mortality of 43% with an NNT of 12. Amazing. The EDT plus the vitamins reduced the MI risk by 51% and a startling NNT of 6. That means if you have a diabetic, which you should be aware, there are studies done by Harvard that clearly show within 12 years, once you are borderline diabetic, even borderline, you are going to have a cardiovascular event within about 11 years. You are already heading towards it. If you start patients early enough with EDTA, you check their toxic metals, and you begin treating them early enough, then the EDTA plus the vitamins reduce the MI risk 51% at an NNT of 6. If you compare statins, you will see a huge difference. It's nowhere close to this. So let's look at the relative risk reduction of the other therapies and see how they fare. So aspirin has a 25% capability in antiplatelet trials. Beta blockers have a 23%. Statins have a 21%, according to some trials. The ACE inhibitors have 19%, and the EDTA in the TACT trial has a 26%, and EDTA in diabetics has 41% overall, 51% for MI, and 43% death reduction. I think this slide clearly shows that the TACT trial tells us that when someone has a toxic metal, especially one of the vasotoxic ones, which we talked about before, mercury, cadmium, gadolinium, lead, arsenic, these are the ones that are going to lead to a coronary artery disease or hasten it for other reasons, that you have a great piece of equipment in your armamentarium to be able to reduce that patient's mortality. Here's the chelation formula that I use. Now, I was trained by Ted Rosenman, may he rest in peace. Ted Rosenman was one of the fathers of chelation therapy. So he's the dinosaur, so I'm the next dinosaur, so they tell me down. I've sat on the boards of pretty much the chelation therapy and everything else. In chelation, I've given probably a little more than 65,000 in my career thus far, maybe more in this particular area. It's exquisitely safe if you follow the rules, and I will give you the rules. This is an IV formula. It works. If you take, and the reason I use 1,500 milligrams is I will show you in a minute, it is safe even up to 2.2 creatinine. Once you get past that, you need to start bringing it down. This way, unless you are very, very capable and you understand this well, using 3 grams like we did in the TACT trial or others do, although it may hasten the reduction of the toxic metals and improvement in coronary artery disease, it makes sense that you use something that's safe. The 1,500 milligrams is safe, and you won't have to do a formula because you'll be good to 2.2 creatinine. You'll see what I'm talking about. 250 cc's of sterile water. In the EDTA, you mix 10 cc's. They're 150 milligrams. It is made. We're talking about disodium EDTA. Disodium EDTA. Actually, with the magnesium, which you see 6 down, you're actually making disodium magnesium EDTA. And the way it works is it substitutes a sodium ion, or I should say a calcium ion. It claws it off and places magnesium in its place, and that's how you get rid of the calcium, and then it is excreted through the urinary tract. Vitamin C, you're using 10 cc's. Vitamin C comes as 500 milligrams per cc, so that's 5,000 milligrams. Procaine, hydrochloride, 7 cc's, unless someone's allergic to an ester. There are a few people that are allergic to the esters, as you recall. The local anesthetics are broken into 2 categories, an ester and an amide. Some people are allergic to the esters, but I gave you the benefit of having it in there before. 1 cc of B complex, pyridoxine B6, a half a cc, and the mag chloride, for the reason discussed before, the vasodilatory 6 cc mag chloride comes as 200 milligrams per cc. So this is basically 1,200 milligrams of magnesium chloride. Notice there is no calcium in this formula for good reason. A, you do not have to worry about tetany for the most part, and B, what sense would it make putting calcium in when you're trying to take it out? Yeah, I would imagine everyone got that. Dexpanthenol, a half a cc, typically comes 250 milligrams per cc. So you're giving 125 milligrams. This is the formula that you use once a week. I'll tell you how to do this in a minute. For renal dysfunction, I did give you the Cockcroft-Gault equation. If you feel like calculating this, please do so. For those of you that are obsessive compulsive, God bless you. I'm not doing this again. I used to do it in my classes. It is unnecessary to do because it's online, and you can literally find the formula and plug it in. And I clearly hope and give you the push to make sure that you do check this formula if someone's creatinine is going up. If it's going up, you'll want to back off anyway. If it's already up, you're going to have to use this formula, because some people can only take 400 milligrams or 200 milligrams. It doesn't mean you can't use it. you would have to go to plug in and use this formula to determine what is safe for them and what is not. At 1,500 milligrams, the formula I gave you here, you're going to be able to do pretty much everybody up to, yeah, that's right, 2.2. Okay. So here's the treatment protocol. The treatment protocol, you give EDTA once or twice a week, always with a 48-hour block in between. So if you give it Monday, or you could do 24, but 48 is better than Thursday. You could do Monday, Friday. You could do Tuesday, Thursday. You can do Wednesday, Friday. It's only 24 hours. Even better is 48 hours. It gives the person a chance to recover, and any of the nutrients that might have been removed will then be repleted by then. I use a mini IV. It's called a mini IV. I believe I have the formula in here for you. I do that every 5th IV with 1,500 to 3,000 glutathione. Let me make this very clear to those people that are doing IVs. If you're not going to do it my way, then you're not doing it safely. If I've done 65,000, I can tell you I've never had a serious problem, then you shouldn't either. So it's easier to do it just this way. It's tried and true. You might also take what I've done over the course of all these years. So I give first a mini. The very first visit, I give a mini. Then I give 4 EDTAs, 1 week, 2 weeks, 3 weeks, 4 weeks, assuming they're getting once a week. Then the 5th one, you're going to do 2 things. You're going to give them a mini, excuse me, pardon me, and you're going to get a complete metabolic profile. So the thing you're doing is you're going to replete them of the nutrients with a mini, which you'll see in a moment. You'll give them the glutathione because it takes 2 glutathione molecules to remove 1 molecule, at least of mercury we know of and are aware of some study. And you're going to check their kidney function, liver function, and make sure that you're not creating any damage. Because if you are and you're aware of it, you can stop. That's the safety. Let me repeat. You start with a mini IV. You do, regardless of whether you do it twice a week or whatever, mini IV. Then you do EDTA, IV, EDTA, EDTA, EDTA. Go back to the mini on the 5th. Give them glutathione, whatever dose you feel appropriate, 1,500 to 3,000 milligrams. IV push, it can be diluted, of course, in sterile water, 20 cc's, otherwise it can burn. Be careful if someone is sulfa sensitive. Glutathione is a sulfur derivative, as you probably should know. If you don't, just don't give it to them. Be careful of that, or use much less and make sure you check it with them. Also get a complete metabolic profile at that particular time. And it's a good habit. We do it in our office. Heather's on with me, my PA. We basically always make sure we see that patient every 5th visit. It's good to hear. How you doing, Mrs. Jones? Oh, good. I'm doing good. Any problem? No, I'm doing good. Are you taking your vitamin? Yes, I am. It gives you a chance to be the doctor and the healthcare practitioner that you all are. You can use daily supportive glutathione in one of the products that you have. I like Plasmanex or nattokinase because they're fibrinolytic agents, and to make sure that you keep them on the thinner, if it's not a thinner side, it's not true. I take that back. Actually, if a clot begins to form, then the job of an enzyme is to interfere and stop that fibrinolytic action. You can have someone's already on a oral anticoagulant. It does not preclude you from doing EDTA, but you don't have to give them Plasmanex or a baby aspirin. But some sort of mild anticoagulation is good, because the newest studies that we're seeing that even just came out last week are showing that it's inflammation and which creating platelet aggregation that's causing the cardiovascular problem. It's all about the endothelial lining. That's a story for another time. If there's lots of inflammation in the patient, I might add DMSO to the EDTA. It does drive it in further. I'm leaving that blank now if it's how much and what kind, because I think that's something more for an advanced talk we can do. And if you want to give them MIC, which is the lipid types of amino acids, which is methionine, inositol, and choline. Someone's overweight, 3 to 5 cc's, make sure there's no lidocaine in there, will be fine. I monitor pretty much from the day they walk in to the day they leave their MDA. MDA is malondialdehyde. It is a byproduct of lipid peroxidation. After the lipid peroxidation begins to get too much and overwhelming, MDA will then create the OONO, or the peroxynitrate free radicals. So MDA is important to be monitoring. It also tells you you're doing a good job in restoring the lining of the endothelial lining, which occupies the 64,000 or so miles of your vascular tree. Sharing with you my IV Mini. This IV Mini is one that I've developed probably 20 years ago. I used it, I teach it. You're welcome to use it as long as each time that you use it, you shout my name. I'm just kidding. You don't have to really do that. Okay. So, but my PA does shout my name every time she uses it. Oh, wait, her husband may be on the line. We can't say that. Okay. So sterile water, 250 mLs you can use, or you notice you can use 0.45 normal saline. What the shortage is, you pick the fluid that's best for you. 250 milligrams of dexpanthenol. I used hydroxycobalamin, 5 milligrams, 1 ml. Why, Mitch, did you not use cyanocobalamin? Because it has a cyanide molecule in it, and I don't never use cyanocobalamin. If any of you are using it in your practice, you should be way above that as a practitioner in physiologic medicine. Why aren't you using methylcobalamin? I don't want to use methylcobalamin because hydroxycobalamin is a much better free radical quencher, especially of the peroxynitrate free radical, especially since the endothelial lining creates that through the superoxide anion and the formation of nitric oxide. And if you're using a nitric oxide product, that combination will make peroxynitrate free radical. Hydroxycobalamin should be your B12 of choice. The complex 1 ml, procaine a couple mLs if they can, half of or 5 milligrams of folic acid, calcium gluconate a little bit, it's 500 milligrams. I never give more than that if I can help it. And the reason we're using calcium is because of the next thing on the board, which is the ascorbic acid, the 500 milligrams per ml with 40 mLs is 20,000. Once vitamin C begins to get above 20,000, it acts as a weak chelating agent in itself. Yes, I did tell you that it is one of the best agents for melting calcifications, but it also is a weak chelating agent simultaneously, and therefore we don't want to cause tetany. So therefore we put in some calcium gluconate to replete these people, because a 1,500 milligram of EDTA removes 150 intravascular milligrams of calcium. So if there's 3 grams you're using of EDTA, you're removing 300 milligrams. Magnesium chloride for the same reason, 400 milligrams. It also helps to dilate. That's why the chloride and the glutathione is necessary, because you want to replete these people before you start and ask on their own stores to get rid of this toxic metal. You have them set. So every 5th visit, 1st visit, and every 5 thereafter, my patients are getting this. So when I say they should get 30 or 40 chelations, Mitch, do you mean that they should have, 30 total? No, they should have 30 of chelation, and then of course the individuals of the IV Mini. Interdispersed. Okay. So your treatment protocol should also include essential fatty acids, not fish oil. Fish oil takes 19 weeks to get out of the cell membrane. We use a product called Cell Membrane Restore. My wife and I, in 40 some years of experience and 350 research papers beyond, we formulate some of these products. You're welcome, if you want to know about them, to write me. You can have them. I don't own the company. You can go directly to the manufacturer and get them yourself. It's not sold on Amazon. They're not going to undercut you. It's just a great product. And for me, it feels good. And for my wife to be able to develop these things that do so well for the patient. If there's inflammation, I'm very into using curcumin. I use the optimized curcumin, the one that we made. It is based upon the Longevita type, which is the only one that actually gets and maintains a blood level appropriately without use of piperine, the black pepper, or anything else, or having to take it with a meal. And it's the only one that the 5 researchers of UCLA ever found that goes through the blood-brain barrier. When it comes to diet changes, I don't think this is the night to go through it, but I think pretty much what dietary things. And the ones to start with, of course, are stop the milk products. Xanthine oxidase in milk causes ongoing bleeding of the arteries. And remember that all milk products have growth factors in it, whether it's organic or not, whether it's 1% or not. There is growth factors in these things. It takes a calf from 80 pounds to 1,400 pounds in a year. You don't need that. Also, what's the secret vasodilatory angina package? Well, I use two things. One is a company called Berkeley Life that produces the best nitric oxide substance I ever found. If you want their information, again, you can certainly text me or call me. My information is going to be at the end. They're great. Again, I don't own the company. I lecture for them, and I haven't even lectured for them really yet. But they are not good. It's that good. So if you test nitric oxide in 1 week, it's back to optimal levels. And for many reasons, it's quite low. And as we age, on the aging process alone, it reduces from 15 years old to 72 to its ground low. In addition, we also make a product from the same manufacturer called Circulation and Muscle Fuel. It's an amazing product for improving circulation. I use it as a pre-workout. I use it as a post-workout. I have lots of major athletes throughout the world that use it. And I use it also for my angina patients and specifically for my heart failure patients, since it does improve chronotropic activity of the heart and an ionotropic specifically, making that heart pump better, and also accentuates the alternative 5-pentose pathway to making and taking adenosine triphosphate and re-entering it quickly so it doesn't ever become AMP and then through the uric acid pathway. And of course, you should monitor the patient's progress. How are you going to monitor? Well, every 5 weeks, we said, or 5 doses. So if you get in 2 weeks, 2 doses, in the following week, the fifth, they're going to get that combination that I send off. It's just simple, complete metabolic profile. Look at it. Is everything okay? Great. Keep going. And I am able to tell the patients the same. The question is, when do you start rechecking the toxic metals? I would say when you have 2 choices, you can wait till you got 30 EDTA treatments in this case, or you can do it at 15 weeks to show the patient you're doing well. If you get it back and it's not doing well and there's other things or it's gotten worse, you can guarantee that that patient is putting it in and you did not get the avoidance, that very prime thing that we talk about in the early treatment. So take a look at that, make sure you recheck it. The great thing about Access's program is that they turn it around in less than 77 days. Most are within 48 hours. So my patients are not waiting for me to tell them, look, here's where we're at, we're doing great, and this is where we need to go. The other part of it is they also will run the excess minerals, meaning when the minerals are finished and they're full, they'll spill over. If your minerals are on the low side, when you get it back and you've started your chelation protocol, then you must tell yourself, am I giving them enough of multi-minerals? Do I need to give them more? Do I need to get them a trace mineral? What do I need to do? And that will give you some clinical cues to what needs to be done next. So another type of detoxification that you can use on lead and also on mercury and a few others is DMSA. That's what we trained you on to do the challenge test for those that saw part 2. If you didn't, go back and watch it. DMSA is good as long as there is no sulfa allergy. Now, the other thing is there are people who just don't want to take IV. There are practitioners perhaps listening that will listen to this program that just don't want to do IV stuff. So don't fret. You can use EDTA orally. There are products like Meritate out there. They suck on 1 a day and you'll get the results, taking a lot longer, but you'll get results. Then you could use the DMSA, but to use DMSA safely, I would suggest very highly that you follow a tried and true mechanism that I've used, which is above. I use a 14-day cycle. I don't do any minerals 24 hours prior or during the taking of DMSA. And I do have to admit, most of the time I forget to tell the patient that, but you should, since I'm teaching it to you. The doses is 10 milligrams per kilo TID for 3 days. So if someone is the typical 70 kilos times 10 is 700 milligrams you want to give over divided doses. So maybe you want to give 250, 250, 250. You're over 50. That's okay. But that's the way you do it. You give it for 3 days. So you'll give 250, 250, 250 day 1, 250, 250, 250 day 2. The same one, similar on day 3. Count off for 14 days and restart the cycle just as if you see here. I would tell you to average is between 5 and 10 cycles. I believe that after 5 cycles, now what's a cycle? So it's 3 days on, 14 days off. That's 17 days a cycle. So 17 times 5, whatever that comes out to, that would be your cycle time. That would be a good time, if you don't want to wait till 10 cycles, to again do your toxic metals and prove whether you're doing a good job or not. Did you choose the right agent? Did you get the avoidance that you thought you were going to get? One last thing in the DMSA usage is you need to take the minerals and sulfhydryl containing supplements 24 hours after last dose, because the DMSA will rob and use this sulfhydryl bridging to get to where it needs to go. DMSA, unlike DMPS, which I don't use, does cross the blood-brain barrier. DMPS, for those that are familiar, doesn't. Sulfhydryl group foods are garlic and onions for those that like to do food type of things. Okay. So you take the minerals, we told you, and you do a provocative test about every 5 cycles. I think we said that. Again, I bring you back to where a little bit we started, which is the entire complement of antioxidants are all built on each other. You can't just give vitamin C and say, hey, I did it. No, it does not work that way, because every one of the antioxidants, for those of you that are quite familiar with free radical chemistry, is that they themselves become a free radical. A vitamin is, by definition, something that has 2 electrons in the outer electron orbit, willing to give up 1 to pair with a reactive oxygen species. A reactive oxygen species has 1 radical and 1 electron in its outer orbit. So you're pairing the free radical, but what does that leave? The vitamin C, for example, leaves it as a free radical. And so you want to re-enter it. So you have to remember, when you're doing this for patients, you don't create more free radicals, even though they are less toxic than the other ones. You balance them. So alpha lipoic acid balances the vitamin C, vitamin E balances the vitamin C, the carotenoids, the glutathiones, etc. So to get good detoxification, even though this is sort of it's an okay diagram, it gives you just a reminder. That's what I did, to give you a shove and remind you that you need to use things that are synergistic with each other. So giving 1 in large dose of any specific antioxidant or vitamin, you're going to cause a problem. Giving even any mineral in larger doses than other will also cause a problem. You all know that if you give too much copper, you don't have enough zinc, you'll get a copper toxicity, etc., vice versa with zinc for copper. And all of them are like that. So you want to be always cognizant about this combination. So I can't see who's who and where. So I'm going to ask the questions, and the next few things that we do, and we'll wrap it up, are going to be questions, and then you can ask me questions. So I have questions for you first. Which chelating agent would you use for this patient? This is a test from Access Labs, and this is what we found in a patient. It's a real patient. I'm not going to say anything. Which one would you use? Oh, the silence is deafening. I wonder if I can show my screen and me at the same time. I don't know if I can. So for those of you that are watching and you're looking at this, you need to see, what is the bulk problem? Is it cesium? Well, cesium's in the water. It's going to be very common no matter where you live. It always pretty much follows with rubidium, which you see is also high at 3004. What toxic metal do we need to deal with? Well, mercury for sure. And you need to deal with platinum, because platinum is a serious toxin. As you know, we use cisplatin, carboplatin in certain cancers. And antimony and arsenic are severe also as well. Arsenic, mercury are vasotoxic, as you've been taught previously. Antimony is an irritant as well. Which ones would you use? Well, there are times that you would overlap. When I see significant stores that I believe of these toxic metals, in this case, I may do exactly the EDTA protocol intravenously I gave you, but simultaneously, starting on a different day, I would also give them the DMSA, because DMSA removes mercury certainly a lot better in antimony than EDTA does from the onset. It will get it, but long down the line, So I need to get all these out as not quickly, but as as efficaciously as I possibly can. So the answer would be you could have used both in this case. Someone has cramps 6 hours after a chelation. 6 hours later, they call you on the phone. I'm having problems. I got cramps. What do I do? Heather, my PA, what would you tell them?
Give them calcium. Yeah.
You know what? I love when you're smart. I hope Mark appreciates you. That's all I'm saying. I'm just saying. Okay. So this case would be very possibly that you remove too much of the calcium, and you don't have to give a whole heck of a lot. 1,000 milligrams of one of the calciums, other than carbonate, because it's elemental, would do this and do a great job. Next question. You give a DMPS chelation to a 52-year-old male. The patient develops a significant headache. The nurse does another set of vitals. Nothing seems to be abnormal. The blood sugar is 94. What are you going to do? Somebody unmute and tell me, show me how smart you are, please. I'm going to take a drink of water while you're thinking. Well, the answer to this is what I taught you earlier in the lecture. It takes 2 molecules of glutathione to remove it. If someone gets a headache during EDTA or any type DMPS or something like that during your treatment, their glutathione stores are deficient, give them some glutathione. Next, during chelation with EDTA, a male 62-year-old patient develops calf tenderness bilaterally. What should you check for? And what would your treatment considerations be? Somebody unmute and tell me. Oh, everyone's nervous. You know what? I'm going to, what's that?
DVT.
DVT would be on my list, but it would be down on my list. Most likely during a chelation therapy, and believe it or not, this was not a male, this was a female. The father of chelation, wife was my patient. And of course, it's always a doctor, wife, nurse, or some healthcare practitioner has a problem. And she had this problem. So what did I check? I checked for 2 things. I checked a Shavastic sign, and you can also check a Trousseau sign. If you don't know what they are, you should. It's 101 physical diagnosis. But I gave them an amp of calcium gluconate. It stopped instantly. This is a calcium. Now, could a DVT occur? Yeah, but it shouldn't occur while you're giving it, because you'd have to have that irritation ongoing. So I have never seen a DVT, nor would I call it off as a side effect that you should be aware of giving this. Question. A patient develops a sudden loss of hearing while getting chelation. What's the likely cause? Too much zinc, inflammation of the 8th nerve or a blood clot, a calcium embolus, or fluid in the middle ear? Multiple choice. Someone unplug and just give me what an ABC did.
Okay.
Yeah, good thought, whoever said A. It's true that if you give more than 10 milligrams of zinc in any given IV, you can cause an irrevocable hearing loss that's unilateral. So never, ever do that. But that would not be the case when it comes to a chelation, because there is no zinc in the formula. So this would be a calcium embolus. It's extremely rare. Thank God I've never seen one, but it does have the potential of doing that. But that was a very good answer, and it was the red herring in the thing. Too much copper is best treated with, let's see how much you may have read, DMSA, D-penicillamine, EDTA, or BAL, British amyloidoside. Anybody? Unhook and tell me.
B.
Yeah, B is correct. The drug of choice for copper over copper is D-penicillamine when you're using an IV formula. There are other things like ammonium tetrahydromolybdenate, which is an oral formula that's a copper killer that I use readily in when I teach my cancer students when they're treating cancer, since cancer uses fibronectin to divide, and that's a copper-derived thing. Here's my contact information. Both mine and my wife is a nurse practitioner, as you can see. If you have some questions about the things that we were talking about thus far, or you want some more information, you're welcome to write us, call us, whatever. I'll leave it up for 10 more seconds. and then I'll take a gulp. I'm going to come back on. I'm going to ask if you have any questions, and then we wrap the night. And then we did a whole hour almost. So with that, let me come back to this, stop my thing here, and see if there are any questions on anyone that's on. Does anybody have any questions? Please feel free to unmute yourself, ask, and I will be glad to do the best I can to give you the answer. Okay, then I'm going to assume we did a good job. Parts 1, 2, and 3 available at Access Labs through your representative. Please feel free to use them as a resource. If there's any issues, they will have me contact you. Begin, if you haven't already, doing the toxic metal evaluations. Retest. You're going to find that your treatment protocols are going to go miles longer when you remove things from the cell that don't belong there and are inhibiting the cell from doing its normal work, allowing oxygen to come in with nutrients freely and taking out the other waste material. Thank you on behalf of Access Labs, the executives, myself, and my wife who helped me put these slides together. God bless everybody. I appreciate your time, and we'll be back next month with some more webinars. Thank you. Have a great night, everybody.